Thanks for this opportunity, and I'm going to dive right in. I've got a lot of information that I want to share, and hopefully you all will walk away with a better appreciation for why colorectal cancer screening is such an important issue and things that can be done at the practice level to improve screening. First, I want to point out that colorectal cancer is the third most common cancer among women and third most common among men. And because it occurs in both men and women, it turns out it's the second deadliest cancer in the U.S. with about 136,000 new cases this year and more than 50,000 deaths expected. Now, on the positive side, there are more than 1 million colorectal cancer survivors. As a matter of fact, I was at a meeting last week, and this number is now up to 1.2 million. These are people who have either battled the disease successfully and moved on, or in some cases are still dealing with colorectal cancer and fighting it. But the death rates have fallen very steadily over the last 10 years. Again, just last week, new data was reported from the American Cancer Society that shows death rates have diminished even more than what's shown on this slide. But this slide demonstrates that we've had a steady fall since the early 80s in the white population. That's the gray bar here. In the African American population, rates continued to rise until late 80s, early 90s, in which case those rates began to fall as well. So we've had falling rates for both whites and blacks since at least the early 90s. However, the rate of fall among the white population has been much greater than that for the black population. So we have a greater disparity in colorectal cancer than we've ever had. There are a number of different reasons behind this drop in mortality and incidence. Certainly, advances in treatment have led to significant improvements in mortality. And we have medications available now that weren't even on the market 10 or 12 years ago. And those medications are extending people's lives when they have advanced disease. Screening, finding cancers at earlier and more treatable phases is also a very important contributor. And it's been shown that screen-detected cancers are much more likely to be in the early stages. They have better outcomes. But most important is the fact that screening not only finds cancer early, but screening can prevent colorectal cancer. And we have evidence that we are preventing probably half of colorectal cancers that might otherwise occur by finding polyps and removing them early. Now, who's at high risk? These are people who have an increased risk of developing colorectal cancer. If you have a personal history of polyps, adenomatous polyps, a personal history of colorectal cancer, if you've had it once, you're at higher risk of having it again, and also people who have a personal history of inflammatory.
Welcome to GoToWebinar, Webinars Made Easy.
A family history of adenomatous polyps or a family history of colon cancer. The polyp history in the family is very often overlooked, so it's important that that be a question as well as asking about a family history of cancer. And then finally, there are a number of relatively infrequent genetic syndromes, Lynch syndrome and familial adenomatous polyposis. If you have individuals identified who have any of the risk factors on this slide, these people are not screening candidates. There is a different set of screening recommendations for these folks. They may need to begin screening at an earlier age, may need to be screened more aggressively, or they may fall into a surveillance pool. In particular, people who've had polyps or cancer need much more frequent assessment. So you need to identify these patients and then recognize that recommendations are different for them. So let's talk about who's at average risk. The average risk pool is much larger. That group of folks that I talked to you about a moment ago account for maybe 20% of all cases of colorectal cancer. 80% of colorectal cancers in the U.S. occur among people whose only identifiable risk factor is age. And because, as this graph shows, the incidence of the disease begins to rise very dramatically, really around age 50, between 50 and 60 is when the most rapid uptake is. Every major organization that recommends screening for colorectal cancer recommends screening for average risk beginning at age 50. The risk also continues to rise as people get older, and therefore screening should be continued until at a time when the likelihood an individual could experience a positive outcome from treatment is no longer present. And from the standpoint of the ACS, that means until an individual has less than a 10-year life expectancy, they should continue to be screened for colorectal cancer. So in addition to age, 90% of cases occur among those 50 and older, but also gender is a risk factor, with males having a slight predominance, but this is really an equal opportunity, Kelvin. In addition, race and ethnicity, with higher rates among African Americans, among some Native Americans, particularly Northern Plains tribes, Alaska Natives, and Ashkenazi Jews. We do not know the reasons behind these racial and ethnic differences, but there's a lot of work going on trying to figure out what these are. There are also a number of modifiable risk factors. People can't change their age, their gender, or their race and ethnicity, but they can change, for instance, their physical activity level. Being physically active is preventative, is actually beneficial, but being sedentary increases risk. Being overweight or obese raises the risk. Smoking, alcohol, anything more than 1 drink a day in women or 2 drinks a day in men. And then finally, type 2 diabetes raises risk. Exactly how and why this occurs isn't clear, but there is a fair body of research now that has demonstrated that type 2 diabetes also puts people at a higher risk. Now, all of these risk factors are still within the average risk pool, but these are people in the average risk pool who are at the upper end of that average risk. So we don't recommend different screening for people who are overweight or use alcohol or diabetic, or even for race and ethnicity at this point. But all of these folks should be aware that they are at somewhat higher risk than the rest of the general risk pool, and should be even more diligent about getting screening started at age 50 and having regular screenings thereafter. Now, there are the most important risk factor outside of age that we can point to is the polyp. There are 2 major types of polyps, the hyperplastic polyp or the adenomatous polyp. Now, under each of those labels, there are multiple subcategories of hyperplastic polyps, as well as multiple subcategories of adenomas. But in general, hyperplastic polyps have a very low risk of transformation to colorectal cancer, with the exception of what you may have heard of as the sessile serrated polyp, which is a form of hyperplastic polyp that does have a high cancer risk. But that's going to be called out on the pathology report. If all that you see on a pathology report from an individual who's undergone screening is 1 or 2 hyperplastic polyps, those have such low potential for colorectal cancer transition that that individual is still considered to be at average risk, and their next colonoscopy doesn't need to occur for 10 years. On the other hand, if an individual has an adenomatous polyp, their risk is much, much higher of progressing to cancer, and therefore that individual now falls into that higher risk group that I talked about and needs more frequent surveillance. That's because 9 out of 10 colorectal cancers we see in the U.S. are thought to arise from adenomatous polyps. Now, while polyps certainly are a concern and raise a red flag, when it comes to colorectal cancer, they truly are our friend. And that's because the transition from normal mucosa to polyp to cancer usually takes 10 or more years. That means that we've got 10 years during which we can find this non-cancerous lesion, remove it, and prevent cancer from occurring. So removing polyps and preventing cancer is some would say, the primary goal of colorectal cancer screening. So we have 2 aims in colorectal cancer screening. One is finding and removing polyps and preventing the disease, but the other is finding the disease at an earlier stage. As I mentioned, screen-detected cancers tend to be found at earlier stages. Does that make a difference? You bet it does. This data also has been recently updated, but the numbers are really very similar. This is the 5-year survival rates for people who are diagnosed with cancer, colorectal cancer, not polyps, but cancerous is found. If that cancer is at the localized stage, has not penetrated the colon wall, 5 years later, 90% of these people, 89.8%, or 90%, 9 out of 10 are still going to be alive. Contrast that with those individuals who have metastatic disease, represented by the red bar at the time of diagnosis. If they have metastatic disease at diagnosis, only 10% of those people are going to be alive 5 years later. So 10% survival versus 90% survival. Yet another reason that colorectal cancer screening should be part of everyone's health care. It's estimated by the ACS that of those 50,000 deaths we expect this year, at least 20,000, potentially more, could be prevented if everyone was up to date with colorectal cancer screening. So how are we doing with screening? Well, these slides, let's focus on the set of bars on the left. The gray bars represent the year 2000 screening rate, and the red bars, 2010 screening rates. As you can see, over that 10-year period, we went from a population-wide, the total population represented by the bars on the left, 39% screening rate across the entire U.S. population age 50 plus, up to 59%. So 39 to 59% from a public health standpoint is really a pretty impressive increase over a 10-year period. However, at 59, let's just say 60%, that still means 4 out of 10 people who should be screened are not up to date with screening. And let's move to the bars in the middle, those who are undereducated, less than high school education. They started much lower, 26%, but they peaked at 44%. So more than half of people who have less than a high school education are not up to date with screening. And then the bars at the far right, people who have no health insurance, almost no change, from 15 to 19% over that entire 10-year span. So health insurance is clearly a very significant barrier to people being up to date with screening. Race and ethnicity also is a challenge or a barrier. Although, again, this data is a little dated, and the recent report that came out last week shows that the black-white disparity in screening rates has almost disappeared. There's only a very small gap between blacks and whites. However, Asian Americans, Hispanic, Latino, and Native Americans and Alaska Natives continue to lag behind. The American Indian Alaska Native exceedingly low rates are particularly concerning, given that, as I pointed out, they have higher rates than the general population of developing and dying of colorectal cancer. Now, it's also important to point out this is data from the CDC that has also been shown in other environments. Although about a third of the population, actually 28% by the latest CDC report, have never been screened. 24% of the never screened are uninsured. 76% of people who've never been screened actually have insurance. So while insurance is a huge barrier for those who don't have it, just because people have insurance doesn't mean they're going to follow through with screening recommendations. So it's important that you not focus your efforts solely on the uninsured, but recognize that there's risk spread across the population. Now, as was mentioned in the preamble of my talk, the UDS measure was introduced in 2012. That was the first measurement year. And these are the parameters that are used to define who the population is. The nationwide rate across all health centers was 30.2% up to date with screening. That's really not surprising, given that, number one, CRC has not been a priority issue in health centers. And given the populations that health centers serve, and particularly with so many women and young children, it's understandable that this has not been paid a great deal of attention. However, given the information I've already shared about the ability to save lives, prevent cancer, I'm very pleased that it now is a UDS measure. But the populations that are taken care of in health centers are those that we already know from the other data I've shared are much less likely to be screened. That is, the poorly educated, racial and ethnic minorities, and the uninsured. So there are a lot of challenges that your patients are facing that we need to talk not about those challenges, but how to get past those challenges. So let's talk a little bit about screening tests in particular. There are 3 screening tests that appear on both the ACS list of recommendations and the Preventive Services Task Force recommendations. And those are colonoscopy, high sensitivity fecal occult blood testing, and then finally flexible sigmoidoscopy. You'll see that FlexSig is laid out on this slide. That's not because it's not a good test. As a matter of fact, there have been a couple of large multinational studies recently that have really validated the value of flexible sigmoidoscopy as a screening test, and it is the primary approach to colorectal cancer screening right now in a number of countries outside of the U.S. that have developed nationwide screening programs. However, in the U.S., it is about as difficult to find a FlexSig as it is to get struck by lightning in many places. Unfortunately, utilization of FlexSig and availability has not entirely disappeared, but is strikingly diminished in the U.S., and therefore it barely appears as a blip on the radar screen when we assess how people are getting screened. So what it really comes down to is, in the U.S., the main tests that are used right now are colonoscopy or stool tests. So I'm going to focus my remarks around those 2 tests. However, if you do have access to flexible sigmoidoscopy, high-quality sigmoidoscopy with endoscopists who are experienced and knowledgeable, then it is still a very reasonable test to offer your patients. So colonoscopy, hopefully all of you are familiar with it. A thin lighted tube with a camera on the end, inserted through the anus and moved all the way through the entire colon. You should view the entire length of the colon all the way through to the cecum in order to have a complete colonoscopy. Patients are usually given some medication to help them relax, which is a very important point when you're encouraging people to get a colonoscopy. Many patients have this visual image of being held down while someone inserts this big tube in their rectum and all the way up to their colon, and they believe they're going to be awake, alert, and feeling a tremendous amount of pain. So simply letting them know that they will be sedated and either will sleep through the procedure or will be so relaxed. Very little pain and discomfort is usually encountered during a screening colonoscopy. But that's important knowledge to share with patients. Colonoscopy has the advantage of being not only a screening test, but it is also diagnostic in that biopsies can be taken during the procedure and sent off for analysis. And it is therapeutic because most polyps that are seen during the course of the colonoscopy are removed during the same procedure, or polyps that are found as a result of other kinds of testing also are removed. So colonoscopy is diagnostic, screening, and therapeutic. And then finally, if the exam is thought to be of good quality and it's normal, all major medical organizations, the ACS and all of the GI organizations, recommend that repeat screening colonoscopy be limited to every 10 years. Now, those recommendations aren't always followed, and many community endoscopists are repeating screenings every 5 years, but there's no organization, including the GI organizations, that recommend screening be repeated at that frequent an interval. But because of the screening, diagnostic, and therapeutic elements, because of the direct visualization of the colon, and because of the much less frequent screening intervals, this has become by far the most common approach to colorectal cancer screening and accounts for about 8 out of 10 screenings that occur each year in the U.S. Is colonoscopy the best test, however? Well, there's frankly a great deal of evidence that would lead one to question that moniker. And the ACS does not declare it the best test. The ACS recommends that any of the screening tests on our recommended list of options be considered and patients be made aware that there are benefits and limitations to all of these tests. So what are some of the, I talked about colonoscopy benefits. Some of the potential limitations are outlined here, and I don't, because of the relatively short time, have time to go into all of these, but it's important to point out colonoscopy is not perfect. Gold standard implies perfection, and colonoscopy is a good test, but not perfect. It misses about 10% of significant lesions, particularly polyps, but it will miss some cancers as well. And there are there are a number of studies that have demonstrated this 10% miss rate in academic medical centers and environments where people knew that their findings were going to be checked. So in community settings where there is not that additional level of quality control and measurement, the miss rate may be even higher. It's also clear that one endoscopist is not equal to the next endoscopist. We have quality measures now that are beginning to be used in a variety of settings. And what these quality measures have demonstrated is that the quality of endoscopy varies tremendously from one endoscopist to the next, despite their level of skill, training, and experience. There are some endoscopists who are much, much better at finding polyps, for instance, than are other endoscopists. But unfortunately, unless you happen to be in an environment where you can get those quality measure scorecards, you really don't know how skilled an endoscopist is. The test is also has a much higher potential for injury on a one-time basis than do the other screening tests. And while colonoscopy is a very safe test, there is very significant evidence demonstrating that about 1 in 1,000 individuals undergoing screening colonoscopy will experience some complication that will require additional medical care. That may just be a trip to the emergency room because of a little excessive rectal bleeding, but it could be a perforation of the colon requiring laparoscopy or open surgery to repair it. It could be, keeping in mind, this is a test that's being done in people in their 60s and 70s. So cardiovascular and cerebrovascular events following a colonoscopy are not uncommon. So a good test, but still some potential risk and concerns. And then I also want to mention the issue of patient preference. There are many patients who are simply never going to get past that mental image they have of being held down and this tube stuck in their bottom, and consequently are not going to undergo an invasive test for what they view as a fishing expedition. They're not having any signs or symptoms, and they're not going to have the tube put up there. Now, they may not tell their clinician that they're not going to have it done. They'll accept the appointment, but they simply don't show up. So the issue of patient preference has actually been investigated by a number of researchers recently, and this study is one of a number of studies that have very similar findings. And that is, if you offer patients more than one test, you can improve your compliance rates. This study was among community health center patients, actually. About 1,000 patients who were due for colorectal screening. All of the patients were educated about why colorectal screening was important. Then one group of patients was told, go get a colonoscopy, or given an appointment and told, go get this test. A second group was given stool kits to take home and collect specimens and return. And then the third was given a choice between stool testing and colonoscopy. The results here are, I think, very clear. Patients who were offered only stool testing, the FOPT only arm, 2/3 of those people completed their screening within 6 months. Patients who were given a choice between colonoscopy or stool testing, again, 2/3 of patients completed their screening within 6 months. But the colonoscopy arm here in the middle, only 38%, so less than 4 out of 10 people completed their screening within 6 months if colonoscopy was the only test that they were given, or the only test they were offered. There have been other studies that have had very similar findings, at times even more striking uptake of stool testing than colonoscopy. So I think that it's clear from the literature that offering people options and recognizing that people have different preferences, whatever clinicians may think is the best test, patients aren't necessarily going to agree with. So let's talk about stool tests. Stool tests come in a couple of different forms, again, like polyps. There are a couple of major categories, and then there are multiple subcategories, in this case, multiple different brands, particularly of FITs, or people immunochemical tests. But the major types are guaiac-based FOBT or fecal immunochemical tests. So I'm going to talk briefly about each. GUAIAC FOBTs have been around for many, many years, at least 50 years in the U.S. These tests were actually the first that demonstrated that colorectal screening could save lives. There were 3 randomized controlled trials performed using fecal blood testing, all of which had positive outcomes, lower death rates, and one of which also showed lower incidence of colorectal cancer as a result of screening. And this led into the growth in screening we've seen over the last 25 years. One of these studies, the one that was performed in the U.S., actually just a few months ago published 30-year follow-up data of patients who were screened with old versions of stool tests back beginning in the 1980s. And at 30 years, the group that was screened still had about a 30% lower likelihood of having died from colorectal cancer. So not only are stool tests beneficial, but that benefit is enduring. 30 years later, still lower death rates from colorectal cancer. Now, GUAIAC tests, all of the GUAIAC tests on the market require specimens from 3 separate bowel movements, which means that these cannot just be collected in the office. You need to send patients home with their collection. And I'll talk a little more about that issue later. The findings from GUAIAC tests are non-specific. That is, there are false positives and false negatives related to a variety of different things, including a number of different foods and medications. And it's also non-specific in that bleeding from the upper GI tract can cause a positive GUAIAC test. Newer versions of the GUAIAC test, typified by Hemoccult sensor, which is pictured here, are much more sensitive, about twice as sensitive as older versions of GUAIAC. So the Hemoccult sensor is the only GUAIAC test that is now recommended. This is a high sensitivity GUAIAC test, and this is what's recommended for colorectal screening. Hemoccult 2 and other older, lower sensitivity versions of GUAIAC are no longer recommended for screening. Now, in addition to GUAIAC tests, the new kid on the block are fecal immunochemical tests, often abbreviated as FIT tests. These tests have some potential advantages. One, they're specific for human blood, so having a rare steak prior to doing this test will not cause a positive. It also is specific for lower GI bleeding. This test looks at a different portion of the hemoglobin molecule than is measured by GUAIAC tests. The portion of the hemoglobin molecule that is looked at by FITs is denatured as it passes through the small bowel. So if an individual has esophagitis or an ulcer that's causing upper GI bleeding, as that blood from the upper GI tract goes through the small bowel, it's changed in such a way that the FIT will not be positive. So a positive FIT is very highly correlated with lower GI bleeding. In addition, to this point, there are no foods or medications that have been reported to cause either a false positive or a false negative FIT. So a positive FIT is strongly suggestive of bleeding from the lower GI tract and much less likely to be a false positive. There are a number of these on the marketplace, and some of the newer versions require collection of only 1 or 2 specimens. However, all of the testing that's been done with these has been done with collection of specimens at home. So there is no in-office collect the specimen and complete the test. FIT available as well. So stool testing is a home-based endeavor. FITs are about as sensitive or maybe even a little more sensitive than Hemoccult sensor. So these are considered high sensitivity fecal blood test as well. They're about twice as sensitive as Hemoccult 2. So again, Hemoccult 2 should not be used for colorectal screening. And then finally, FITs are somewhat more costly than our guaiac tests, but they also are reimbursed at a higher rate by insurers, including Medicare. So that switching over from a guaiac test to an FIT is often a cost-neutral proposition, or I've even talked to some clinicians who say that they actually make a couple of dollars on the switch because of better reimbursement. Now, there are a number of stool quality issues that have to be kept in mind. If you're going to be doing stool testing, you want to make sure you're doing it right. Number one, as I've already pointed out, is in-office stool testing should not be done. Doing a digital rectal exam and at the same time smearing whatever is found on a card or putting it in an FIT kit and processing it is not colorectal cancer screening. It is not. That has been shown to be worse. And I'll talk to you about the data demonstrating that. This was a study of more than 1,200 patients who were scheduled for screening colonoscopy. These patients, all prior to their screening colonoscopy, went home and collected 3 stool specimens on old guaiac cards, the low sensitivity hemoglobin 2 cards, because the study was performed in 2005. These patients also then had an in-office digital rectal exam, and whatever was found on the glove was smeared on a card, and that was tested. And then they compared these results, the stool test results, with what was found at colonoscopy. Of patients who had cancer found on colonoscopy, only 9.5%, basically 10%, 1 out of 10 cancers showed up as a positive single sample FOBT. 1 out of 10. So 90% of patients with cancer would have been told, you're fine, come back next year, if all they had was that single sample in-office test. Now, cancer detection was higher, but still not great for the required take-home sample, but 44%. So 4 times better cancer detection. And of all lesions, that is cancers and large polyps, the single sample in-office test found only 5%. So 95% of patients with cancer and polyps would have been told that everything is normal. Now, this points out, number one, the fact that the single sample in-office digital rectal exam guaiac test is worthless and should not be used for colorectal screening. But it also reinforces the fact that even if done correctly, especially using older tests, difficult too, that a number of cancers and polyps are going to be missed by stool testing. So it reinforces the importance of doing this testing every year. So if stool testing is what you and your patients opt for, choose, or are forced into by circumstances, it needs to be repeated every year. Now, we are hoping that someone is going to repeat this study using Hemoccult Sensa and or a fecal immunochemical test. That would certainly give us some better information to go on. And we suspect that the overall sensitivity of the take-home approach would be markedly better. But there is no evidence that single sample in-office testing using either guaiac or FIT is effective, and therefore that should not be done. Patients should be sent home with their stool kits and collect their specimens at home. So, again, basic stool quality issues, no single sample in-office testing, use high sensitivity, either high sensitivity guaiac or FIT. Testing should be done annually. And then finally, all positive screening tests need to be followed up with colonoscopy. It's shocking how many patients have a positive FOBT that either gets no follow-up at all, or patients are simply told, well, that might have been a false, so take this home. Or maybe it was your hemorrhoid, so let's ignore it. Every positive FOBT or FIT is cancer until proven otherwise. So colonoscopy is the only appropriate follow-up. All of these issues are outlined in this one-page front and back document that can be downloaded from the website here at the bottom of this page, along with a lot of other tools and resources related to colorectal cancer. But this tool outlines the important elements of a high-quality screening program and also goes into a little more detail about the sensitivity and specificity issues of the different forms of guaiac and FIT. So let's move on now to why the screening rates are where they are. When we ask patients why they have not been screened, a lot of different reasons pop up. Low awareness of colorectal cancer as a personal health threat. Most people have heard of colorectal cancer. As a matter of fact, awareness is now greater than 90% in general public surveys. They've heard of the disease. They know it's an important disease, but they still have the perception, well, if I'm not having any problems with my bowels, I haven't seen any blood, nobody in my family has it, so it doesn't apply to me. That is just dead wrong. The patients don't know that. There's a lack of knowledge of screening benefits. The idea that we can actually prevent cancer by doing these tests and finding something and removing it, that's a foreign concept to patients. They've never heard of polyps. They don't know what polyps are, and they don't know that we can prevent cancer by doing these screening tests. There are also fear, time, cost, access, a lot of different issues. But one thing that comes up over and over in every evaluation we do with people who have not been screened, they haven't been screened because their doctor never told them. Now, clinicians often have the perception that their patients have no interest in this test. But the reality is that most patients, if educated about why it's important and encouraged to do so, will follow through. So why is that not happening? Well, the reality is that 98% of primary care clinicians say that they are doing colorectal cancer screening. And we have no reason not to believe them. However, they're doing it on a demand basis as opposed to an organized approach. And what that means is patients come in with a lot of different demands. They need refills on their blood pressure medicine, they're having URI symptoms, they're having back pain, their knee is bothering them, a variety of other things that end up chewing up a great deal of time in that visit. Clinicians are in most instances in systems where everything is dependent on them remembering to do something. So if there happens to be some time during the office visit, if the clinician thinks about colorectal cancer screening, if the patient is immediately receptive, then maybe they get that referral. But if all of those circumstances don't come together, then screening doesn't take place. What we need is a system that is much more organized around getting the screening done. Take, for instance, the example of pediatric immunizations. Never in raising 3 children did I go to the pediatrician's office and have to remember to ask them whether or not a vaccination was needed at that time for my kids. They're on top of it. They know what is needed, when it's needed, and their office is taking care of it. In most of the cases, it wasn't the doctor wasn't having to remember it was done. His staff or his office system had already determined what was necessary, and they were taking care of it for him. So looking at that model, we recognize that we need a similar model around colorectal cancer screening. And therefore, the ACS teamed up with the National Colorectal Cancer Roundtable, which is a organization of organizations, about 70 organizations, all involved in the fight against colorectal cancer. And then we worked with some experts at Thomas Jefferson University to pull together all of the resources that we could find around colorectal cancer screening and create a compendium of office-based practice change elements to improve colorectal cancer screening. This original compendium weighs in at about 150 pages if you include all of the appendices. But it is a great tool. It has all of the guidelines from the major organizations, a lot of office change tools, a lot of helpful bits and pieces that can really make a big difference in getting your patient screened. However, it was frankly too lengthy for most primary care practices. Some academic practices, some major health plans, the CDC, these larger groups took this on and applied it in a variety of settings. But for the average small practice, it was a bit much. So we created a variety of other versions. So we still have the original full-length version, but we also have what we call our action plan, which is an 8-page version. We took 150 pages of information and condensed it down to 8 pages just for you. So the action plan version highlights the key elements that have been defined in that larger, deeper tool, and it refers back to the larger original version if you want more detail. That action plan has actually been turned into an e-book by the Pennsylvania Academy of Family Physicians. It was at it this link. And then there is a version specific for community health centers. That was developed by a researcher out of North Carolina who was working with community health centers and came across our toolbox and said, this is great, but we need to winnow it down. So that version is about 30 pages, and again, specific to the needs of community health center clinicians. One of the key underlying principles for all of these versions of the toolbox, whatever version you're using, is the clinician cannot do it all. We need to engage the entire staff. This is all about teamwork. And given that community health centers have for many years, even before I ever heard of a patient-centered medical home, when I was working in a health center 20 years ago, it was all about teamwork. So engaging all of the members in the team and using their time effectively so that it's not up to the clinician to remember to have this discussion with each age-eligible patient. Now, there are a number of what we call essentials. There are 4 essential components of practice change that can increase colorectal cancer screening, and these are outlined here. I'm going to talk very briefly about each of the 4 essentials. Number 1, recommendation. You need to figure out what the messages are that you and your staff are going to share with patients. You also need to figure out the risk assessment component, and that is you need to be able to identify those people that I pointed to earlier as being at increased risk. The people with a personal history of polyps, a family history of polyps or cancer, any of those other syndromes, because those people may need to start screening at an earlier age and be screened or followed up more aggressively. So you have to find those folks. But then you also have to have messages that go to the general population. And figuring out how to talk to your patient population is very important. You need to address the fears and concerns that patients have. You need to find educational tools that will make patients aware of why colorectal cancer screening is important, reinforce the prevention message. Again, most patients have never heard of polyps, letting them know that we're trying to find things before they turn into cancer, and also making sure that they're aware that even if we miss the prevention opportunity, if we find cancer early, it makes the difference between 10-year survival and 90% survival. 10% survival and 90% survival. So all of those need to be part of your basic message. Essential number 2 is developing a screening policy. So having a standard course of action for screening that everyone in the practice understands and buys into. Part 1 of this is simply deciding which guidelines you're going to use. Are you going to work based on the ACS guidelines and all the different tests that are available there? Is that even available within your community? Are you going to focus on the Preventive Services Task Force guidelines? Or are you going to focus just on colonoscopy and stool testing? These are the tests, but then going the next step and defining how we do it. So you need to know what the screening resources are in your community. Even if your clinicians lean toward colonoscopy, if there are not endoscopists who either will take care of uninsured and underinsured patients on a regular basis, or who take the kinds of insurance that your patients have. Maybe they put limits on their Medicare patients. You need to know who takes what. And you also want to the degree possible, assess the quality measures that if in your particular area, those quality metrics are beginning to become public. You want to find out which endoscopists are doing a good job. And you also want to look at very basic things like, after a colonoscopy is done, do you get a report back to your health center so that you know what was found, you know what's being recommended as follow-up for your patient. So all of those things should be part of your screening policy. But it starts with identifying the guideline, which guidelines you're going to follow, and then how you're going to implement those tests. On the insurance issue, one thing that I feel compelled to mention is a very important point, and that is that many patients are not aware that one of the provisions of the Affordable Care Act that has already been in place for 2 years now or more is that colorectal cancer screening, along with other preventive services that have a grade A or B recommendation from USPSTF, are available with no copay and no deductible. That means the vast majority of your patients who have insurance, either private insurance or Medicare, can get a colonoscopy or can have their annual stool test with no associated out-of-pocket cost. Now, there is unfortunately a loophole that persists in the Medicare program where individuals can go to sleep thinking they're getting a screening colonoscopy, but if a polyp is found in mid-procedure, that coding now changes from screening to diagnostic, and they may end up with a copay related to a polyp removal. That'll happen in general in a third or so of patients in the Medicare population. But that is not always the case. It depends in part on the endoscopist. And in addition, there is a great deal of work going on through the ACS and a number of other partners to try to close this loophole. Fortunately, that loophole has already been closed in the private insurance marketplace. When the Affordable Care Act first kicked in, that same interpretation was occurring in the private marketplace. But now it's been clarified that there should be no cost. If the patient goes in for a screening colonoscopy, whatever is found, it remains a screening colonoscopy. So, important point for your patients to be aware of: no copay and no deductible for most of these procedures. Essential number 3 is reminder systems, and using reminders both for clinicians and patients has been demonstrated to markedly improve screening rates. So you need to figure out, one, how your practice is going to let people know they're due for screening. So how do you make sure that you find every 50-year-old when someone's turning 50? Do you have a way to send out a postcard, or at least when they show up for their first after 50 visit, make sure that you flag them and get that screening discussion taking place? Also, how do we remind the physicians and other clinicians in the practice? In addition to that upfront reminder to make the screening recommendation, we also then, as part of our reminder system, need to track and follow up to make sure that people who are given stool kits, for instance, return those kits. It's been demonstrated in study after study that simply sending out a reminder or making a reminder phone call to those people who haven't returned those kits within a set period of time, usually 2 to 3 weeks, by making that call or sending out a postcard, you can double the return rates. So a little bit of additional investment in time and energy has a great payoff in terms of getting people screened. And then finally, how do we make sure that everyone who has a positive FOBT or FIT actually gets a referral for colonoscopy and follows through? How do we make sure that everyone who is referred for screening colonoscopy gets the test and find out what those results are? So we need to put some sort of logs and checks and balances in place to make sure that the entire loop is closed once around screening. Simply getting a recommendation to the patient and then no information on what happens afterward is not a high-quality screening. Now, in terms of patient education, the patient's cues for action, this video is available online at the ACS website. It also is available as DVDs that you can order through your ACS representatives if you want to send patients home with the DVD. But either way, this is a 7-minute video that goes into a fair amount of detail about why colorectal cancer screening is important, and then uses a lot of imagery in simple language to explain the different kinds of tests that are available, so that patients can then have a discussion with their clinician about which test they prefer. And the clinician doesn't have to spend all of that time describing what the different tests are all about. This is available in both English and Spanish, and again, it can be viewed at our website or at no cost. This is an example of the kind of tool that's been created in the original version of the toolkit and can be downloaded from the online original version. All of these tools were created in Microsoft Word so that you can customize them. You can add your office, your clinic logo. You can add individual clinician signature lines. But this is telling the patient, when you turn 50, it's time for your colorectal screening. We also have postcards saying we gave you these stool kits and you have to return them. It's very important. Please send them back. So basically, we've created a variety of different templates so that you don't have to. All you have to do is download it, slap on your letterhead, print it out, and put it in the mail. We also created these as fold-over HIPAA-compliant postcards so that there'd be no concerns about patient privacy. So, essential number 4. I talked about the first 3, making that recommendation, the practice policy, reminders, and now essential 4 is measuring practice progress. You need to know how you are doing, and you find that out by working, again, through the staff, talking to everybody on the staff, and figuring out what's working and what's not working in terms of the processes you put in place. But you also need to have, before you even put any of these processes in place, you need to understand what your baseline is. Now, all of you have collected UBS data for reporting for 2012, and are probably in the process of collecting 2013 data. So you may have a very good idea of where things stand right now. But in some environments, it may be necessary to look on a clinician-by-clinician basis and figure out who's doing what. It's been shown, and again, in a number of different studies, that providing individualized feedback to clinicians by having scorecards that show, 1, what the overall center rate is, 2, what each clinician's currently doing, and 3, what the targets are. That kind of individualized feedback coming on a regular basis, usually monthly or every couple of months, can really help refine people's focus on this and improve screening rates. So putting in the time and energy. If you can do this through your EHR, fine, but we've also found that many EHRs don't do a really good job of tracking colorectal screening, in part because of system design, in part because of the fashion in which information is often input. For instance, a lot of systems simply use free text to input both fecal testing as well as colonoscopy reporting. And those free text fields then are not searchable and aren't captured when you start trying to run a report in colorectal screening. So modification of the EHR, modification of how information is being input into the EHR, or simply going to hand audits to really look for evidence of colorectal screening recommendations and follow-up are the ways to get this kind of information. Now I want to conclude with a final word about the association between ACS, the Colorectal Roundtable, and the National Association for Community Health Centers. We have developed a very strong working collaboration over the last few years, and as a matter of fact, published this paper outlining high-level strategies for improving colorectal cancer screening in community health centers. It's available at the CA Cancer Journal for Clinicians website, which you can access without any cost. You can access and download this paper, but it goes into some level of detail about some of the issues I've talked about, as well as other important things to keep in mind as you try to improve screening in the community health center environment. Part 2 of this is we've taken some of these recommendations and are now putting together some pilot studies in various parts of the country to begin to create stronger links between community health centers and their medical neighborhoods, medical communities, to get some of that important follow-up care that is often a challenge. And then finally, you can find information about colorectal screening as well as all other cancer-related issues at these links on the American Cancer Society website. And I urge you to encourage any of your patients who are affected in any way by cancer, directly or friends or relatives affected, to use our 800 number. It's 800-227-2345. Is a 24-hour-a-day, 7-day-a-week information line where all sorts of questions can be asked about colorectal cancer of our health information specialists. Information can be sent out to patients. It is a tremendous source of support and markedly underutilized, particularly by poor and minority communities. That is the end of my talk. So if you all want to take it back over.
Thank you so much, Dr. Brooks, for all the information and resources that you gave us and provided to us. We will briefly open up a session for Q&A. So if you are able and have a question, please fill just fill out the box to your right in your toolbar, and we'll get that question over to Dr. Brooks. One question that we do have is, are there state or federal programs that offer free or low-cost colorectal cancer screening?
There are, the CDC has actually funded programs that are present in, I believe, 24 states and another 4 Native American tribal territories that offer low-cost or no-cost colorectal screening. You would have to go to the CDC website. You can find out whether or not your state is one of those that has such a program, and then it would provide contact information about how to get into that program. One of the challenges with that, however, is it's strictly a screening program, and then they do have some links to follow up there. But if, for instance, you have already screened a patient in your practice and found a positive, you cannot refer them to the CDC program. There are other programs in different localities. For instance, the city of New York has a very aggressive colonoscopy screening program, and you can refer patients into that program if they happen to live in New York City. But there is a continued effort at the federal level to increase funding for the CDC program and expand it to include all states. And as a matter of fact, there will be a new request for proposals coming out from the CDC, I believe this summer, asking for new applications for states to expand the program.
Wow, very good. Thank you. And let's see, does ACL or did ACS create a tool that health centers can use to incorporate into their EHRs to kind of assess people who need to be screened, or to kind of watch those age parameters for when they need to update their CRC screening?
Well, unfortunately, as any of you who work with EHR knows, if you've seen one EHR, you've seen one EHR. There are so many different versions out there that creating a fix for EHRs in general isn't possible. What we have done is we've collected some information about some of the challenges that seem to cut across EHRs, and we're putting together a report that we will make available actually to health centers, and that includes some basic recommendations like what I talked about, making sure information is put into searchable fields as opposed to open text fields and that sort of thing. But we also plan to use that report to go to the EHR vendors, those that are most prominently recommended in community health centers, and have a sit-down discussion with them and tell them these are the challenges that your customers are facing, and put the onus on them to start to create fixes. There also are a couple of fixes that have been developed by community health centers, and we're trying to get detail on those. Those are for specific EHR systems. But if you happen to have one of those systems, there may be a fix that's been created that we could share more broadly.
Oh, wow. All right. Thank you for that. So that is all we have for Q&A right now, and I would like to thank you again, Dr. Brooks. Before we end, I just have a few announcements. Please visit our website for our archived webinars. As I mentioned before, they will be made available to you through our website. Also sign up for our mailing list so you can receive information about upcoming webinars such as this one. Follow us on Twitter, and we do update our Twitter account and do tweet about our webinars, about resources and information that's available. And we do have partners such as ACS that we follow as well. We do have our upcoming symposium June 9th in Alexandria, Virginia. Please see more information from our website to attend and register for that. And feel free to contact any of us listed here. We are the staff of the National Center for Health and the Aging about resources, ways we can assist you, and any additional information and resources related to this topic. Thank you to everybody who attended, and thank you again, Dr. Brooks.
All right. Thanks for your opportunity. Take care.
Bye.
Goodbye.